Thank you all for coming on an evening. And my name, as was mentioned, is Brian Culp. I'm one of the docs at Princeton Orthopedics, and my specialty area is in joint replacements. Hip and knee joint replacements is what I focus on, and treat all brands of arthritis that fall in those realms. I've done a little bit of unique training that's kind of on, we'll call it like what's kind of up and coming with robotics and with outpatient joint replacements. So I was going to kind of talk about that because that's really what's new. But I can talk about classic things if that's an interest area for any of you guys, or I can talk about whatever you want. Really, it's your guys' time here. So, I run our outpatient joint replacement program. So what outpatient joint replacements is actually some of my patients who come in for a knee replacement or a hip replacement in the morning, go home that afternoon. And it's very different from how joints were done historically. So that was what I was going to talk about. But if we would decide we want to go down another avenue, we can go down that avenue too. So a little background about arthritis. So what is arthritis? We all have joints that move in our bodies, and they're covered with cartilage. And cartilage is a very smooth tissue. It's meant to be, it's as smooth as ice. It's meant to be so smooth that the friction is exceptionally minimal, which is what allows us to walk. And unfortunately, when you develop arthritis, and arthritis is a disease of cartilage, you start losing that smooth tissue, and it's not gliding smoothly. So in the case of a knee, you might lose it on the end of your thigh bone, called your femur, or you might lose it on the top of your shin bone, called your tibia, or even your kneecap. So I won't go too scientific in this doc, but thigh bone, obviously, shin bone is the bottom half, kneecap is in the middle, and this white, this is a very washed out image here on the screen, but this white kind of smooth lining is the cartilage that covers the cap. There's some cartilage on the bottom of your kneecap. There's some cartilage on the top of your shin bone on your tibia. And as your knee glides, you don't feel it. It just moves smoothly. In a hip, you have a ball and a socket. And similarly, each of those is covered with that smooth cartilage. And so when we start to have arthritis, that cartilage breaks down. And it can break down for a number of reasons. It can break down because of genetic predisposition. Perhaps your parents all had arthritis and you just drew the short straw of the gene pool. It can come from things that you've done over the course of your lifetime. So people who've had sporting injuries, maybe people who were runners but weren't good runners. Perhaps you've had a major trauma, ACL tear, fall. Those can all contribute. And also things that you've done with your lifestyle habits. So we know that people who carry a little extra body weight put more pressures on their joints, and their joints break down a little faster with obesity. Smoking actually causes a decreased circulation over your whole body, but in your joints that's relevant as well. And you can, when we go into smoker, sometimes the cartilage even looks a little discolored or yellowish, which is not great. And when your body loses cartilage, your body can't grow cartilage. And we can go down another avenue if it's a desire of you guys to talk about stem cell. And stem cell is kind of something that's a novel treatment modality that I don't think we've got a full handle on yet how to use very well. But your normal anatomy cannot regrow cartilage. And so, but it can grow bone quite well. When you break a bone, your body heals itself. So when you start losing cartilage, and there's all that room for it to move around and slosh around in there in your hip or your knee, your body says, I got something I can fix that with. And it grows something. It grows bone spurs. So it develops these little sharp edges around the side of the socket, or in the knee, it's on the side of the tibia or on the thigh bone that can kind of dig into you and are a little uncomfortable. So that's where you end up getting those kind of things. And when we look at an x-ray, people say, well, are you going to be able to see this in my office? Well, sure. When it's bad enough, you can see it quite clearly. Most people can see it as they walk. You'll see people who walk like John Wayne a little bit, or people who've got pretty knocked knees. What ends up happening is you have that cartilage, and if you see on this x-ray picture here, there's space between the thigh bone and the shin bone, and that's where the cartilage and the meniscus are. But on the inside of the knee, there's no space. That black, it's not actually black, it's clear because it's not calcified. On an x-ray, it's clear. So that clear space is gone. And the bones actually have nothing between them to cushion them. And when we say it's bone on bone, it's because the bone's actually resting on the other half of the bone. That's when we say bone on bone. And you don't need an MRI to see that. It's very apparent when it's pretty bad. And a hip is very similar, where you see there's supposed to be space between the socket, and there is no space. And when we go in and look at it in real life, and I apologize if this is people are squeamish in any way, but we'll often see that it almost looks like a sinkhole in the highway, like you're driving in New Jersey. There's spaces where there's white cartilage and then just nothing. It just kind of falls off like a hole. And that can be on either the thigh bone. This is the end of the thigh bone. It can be on the shin bone. It can be on both. It depends how bad it is. So that's where those bone-on-bone contact regions occur, is when you have no cushioning and then you stand up on your feet. So when we take x-rays in an orthopedist office, we always take them standing up, because when you lay down in the emergency room, there's no gravity, and you can get some artificial space. When there's not really space, it's just that you're not standing on your feet. And it hurts arthritis hurts when you stand, not when you sleep. Well, it can hurt. If it's bad enough, it'll hurt when you sleep too. As I mentioned, bone spurs, the changes in alignment. Again, this knee is one where you can see that cartilage is slowly eroded away on the inside. This person looks like John Wayne when they walk, because that shin bone is collapsing inward. Not because the bone is changing, but because there's nothing cushioning between the bones. So that's the alignment becomes changed. So how do we treat this? So if you come to my office for arthritis, or just for knee pain, because you don't come saying I have arthritis, you come saying my knee hurts or my hip hurts. I can't tie my shoes anymore, or it hurts to go up and down stairs, or sitting in a long car ride is just really not pleasant anymore. And so we take an x-ray and say, okay, you've got arthritis. All hope is not lost. We can do something for you. We don't just take you to the operating room that day. We try some things, right? So we try exercise. People say, how's exercise going to help? I have arthritis. Well, and I use a lot of car analogies. So I use your knees like a tire. You have treads, there's some air, it's balanced or it's imbalanced. So exercise is balancing the muscles around the knee that can compensate for the fact that that tire maybe doesn't have as much air in it as it should, or maybe the treads don't quite reach the head of your penny. So there is some value that stretching and exercise can help you feel better, helps you with your range of motion, helps you walk better. There's different types of injections that we can use, and I can belabor that later on, but the traditional ones are either cortisone shots, or there's a type of a lubricant type gel that we use called viscose supplement or hyaluronic acid. So we can use those to help people. Some people say, is that going to work for me? It depends how bad your arthritis is. So if you look at that pothole picture, I can inject motor oil in your knee. You still got a big hole. And it may or may not work to the cortisone shot or even the gel shots. Medications, what kind of medications? We don't really like using narcotics. Obviously, we know narcotics are a big issue in this country, and we try and discourage people from either taking narcotics. If your family doctor gives you a Percocet for your knee arthritis, that's a bad treatment. You don't want to be on narcotics. We talk about things like Tylenol, or anti-inflammatories like Advil, Aleve, Motrin. You can even do some prescription strength versions like Celebrex, Meloxicam are good ones too. And Tramadol, which is not quite as strong as a narcotic, but it does have some pain relieving functions, a little stronger than Tylenol, can all be safe to help control your pain. Again, we're not necessarily fixing that region of cartilage that's missing, but it can help control your pain. Weight loss. Undoing how you got there. So if you carry a lot of weight, every pound of pressure on your joints actually multiplies. Some people say it's 5 pounds for every 1 pound of pressure. So if you lose 5 pounds, you take 25 Newton force pounds off your joint. Can feel a heck of a lot better when you have some arthritis. And then things that people don't want to use, like a cane or a walker. Say, I'm too young for a walker. I realize that. But you have bad arthritis and it hurts. So you don't have to use it, but it's an option there. Swimming, pool therapy are all great modalities that are, if you can't exercise on the ground, okay, we can do it in a water environment that's a little less weight on your joint and can make it easier to exercise. And then the last category for treatment is surgery. And again, if you've got a tire that has no treads and maybe you have some large holes in it, and maybe your wheels are a little out of balance or your car's a little shot, we can't just scrap you. Obviously, you still want to keep living life and enjoying yourself. So sometimes we have to do some surgical intervention to replace it, because if you inject some cortisone or some gel or some stem cells into that tire, it doesn't necessarily regrow itself, right? It still has a hole in it and maybe no treads. So when we talk about surgery, where I was going to go with this talk, and again I can go in another direction, is surgery is a little different than it was in the 90s, the 80s, and even in the 2000s. We still use strong implants. It's not like we're cheating and, blowing air in there. We're still using titanium strength implants, skilled surgeons, skilled anesthesiologists, but we've got better implants now, better surgeons hopefully, and some better anesthesiologists and anesthesia techniques. And that's what we're going to go into. I'm sure you guys have heard of minimally invasive surgery, which has a lot of connotations of what that means. There's different ways you can go into it, whether it's a long incision or a small incision, because the patient cares about how their scar looks. I care about how your knee feels. Your scar is important too. So what is minimally invasive? Minimally invasive really should be, to a surgeon, it should be doing the smallest incision possible, but being able to do it safely. So minimally invasive, if you're going to put an implant in that's yay big, this is not minimally invasive. Some people say, can you laser the implant into my knee? I haven't figured that out yet. Teleportation is one of the things we're working on, but finding ways to get that in through a smaller and smaller incision involves better and better techniques and better instruments, which I can talk about instruments in a minute. We do better with the controlling of your pain. So back once upon a time ago, you used to got a button in your hand and you'd be in bed for 3 days, and every time you push the button, you got a little squirt of morphine. We don't really do that anymore. In fact, I don't even use morphine on my patients. And some patients even go on home the same day. I did 4 today. They should all go home tomorrow. And probably 2 of them could have gone home today, but he was 80 years. The first guy was 80, and I said, I'd rather monitor you overnight. I don't think you're ready to go just yet. But he said, get me the hell out of here. So, but there's some newer techniques that allow us to do that. So I always ask people, I don't know if anyone in the room has a joint replacement or perhaps has a family member who's had a joint replacement, but I always ask people, what do you think about a joint replacement? So has anyone ever had any experience personally or in a family member?
I have a hip replacement.
Okay. May I ask how many years ago it was done?
I believe about 8.
Okay. So 8 years, they were, that's still in this current the 20 teens, and we were already doing a lot of these things. So how many days were you in the hospital for?
A short time, like 1 or 2. I don't remember exactly.
Did you have to go to a rehab center?
I did not.
So you were working with someone who was pretty cutting edge. So I know in 2011, a lot of patients still went to a nursing home or a rehab center for upwards of 2 to 3 weeks. That wasn't uncommon. But I always say, well, what if you had to have a colonoscopy, which most people could raise their hand and say they've had one of those.
I had a ankle replacement, total ankle replacement last year.
Okay.
At the Warsaw before.
Okay.
But I want to know if that it matters the age, since I'm only 36.
So age does matter quite a bit, and so when joint replacements were designed, really in the 1960s, they were designed for patients with rheumatoid arthritis who were kind of a little more aged than you are and probably had less demand on their joint. They were wheelchair bound and they were quite happy to get up and walk to their kitchen. Now in 2020 or 2019, we're doing joint replacements on people as young as 20 years old, 30 years old, 40 years old for bad disease. When the old rule used to be, until you hit 65, you waited it out till you were 65, and you were stuck with what you got. So now, we're doing them, which is what's enabling some of these cooler techniques, is we've got healthier people who are undergoing surgery. However, the demands that you guys are going to put on these are going to be much greater. I have one of my current patients who I did a couple weeks ago is very concerned if he's going to be able to hit this year's ski season in Vail. And he's 3 weeks out from his knee replacement. And I don't know if he's going to make it to Vail this year. I don't know if I'll make it there ever. But your age does matter quite a bit, because what you're going to expect out of your total ankle replacement, and I, full disclosure, am not a total ankle replacement specialist. I primarily only do knee and hips. But you're going to put a lot more demand. It can wear out a lot quicker. It can get loosened from the bone a lot quicker. And perhaps the reason why you have pain is perhaps that it's not necessarily functioning the way it was intended to. But I don't know, because, again, I don't know you personally, nor do I.
It really hurts more than before surgery.
Have you been back to your doctor?
Oh, so many times, and it's just like, that's normal. I mean, you have to get used to it, and maybe you do it too much, and and just medicine, and it's not helping.
Well, it would be a worthwhile thing to get perhaps a second or third opinion from, okay?
Yes, and one doctor in Camden hospital, Camden Hospital.
Mhm.
I forgot his name. He said, well, I don't want you to get worried, but I want you to have in mind that maybe a amputation might work.
So I think
Slow down.
I think your unique circumstance is probably not the norm. Many people are very satisfied with their joints. Otherwise, we wouldn't be doing them. Again, that's probably not, maybe we could talk off after this, because that's not my area of expertise is ankles. And I don't exactly, I don't know if it's an infection or if it's, again, I'm not meaning to diagnose you here in front of a room of people, but I think it would be a worthwhile thing we could talk about afterwards. And if I can help you, I'd be happy to. But I'm not sure why, because I don't do a lot of ankle replacements myself. How many days did you spend the night in the hospital for your ankle?
No, I went back home.
Okay, just out of curiosity. So, since that was where I was headed in this segue, was historically colonoscopies were an inpatient procedure as well, back when they used to actually look through the end of the tube and see what they saw. And now, if I had told you you had to spend 2 or 3 days in a hospital for a colonoscopy, you probably wouldn't be very happy with me. So certainly joints have changed. This graph is reflecting hip and knee replacement surgery, because I don't have anything on my talk about ankle replacements. But in the 1980s, 10 days in a hospital followed by a nursing home stay for 3 weeks. 1990s, 5 days, still got to go to a nursing home. You just didn't have to spend 2 weeks at a hospital. Then you're looking into the early 2000s. Okay, maybe you only need to go to a nursing home for 7 days. Okay, kind of where you were. Late 2000s, maybe early, people are starting to decrease their length of stay. Maybe you don't need to go to a nursing home if you're really healthy. You might even go home. And after a day or two, and to the point where even now in this decade where people are going home on the same day. And there's a lot of reasons that we're able to do that now. So obviously we should always acknowledge those who have helped got us here, and these 3 gentlemen, Dr. Berger in Chicago, who's very well known for having developed outpatient joint replacements. Dr. Tria in New Brunswick was a specialist who developed a lot of minimally invasive techniques, and Dr. Delavalli in Chicago as well were these gentlemen who really pioneered this and trained me. So how do we help patients in that circumstance? Certainly we have to figure out which patients need a hospital. Some patients do need a hospital. Some patients are sick. I have patients, I did a 94-year-old last week. She went home the next day. Figuring out what their medical problems are. Do they have heart problems? Do they have blood pressure problems? Are they going to be able to walk? Do they live alone? How many stairs are in their home? Do they have some allergy to one of the pain meds that we use nowadays? 2 is addressing fear. It's scary to think that you might go home, especially if you're going to go home the same day. If you're young and healthy, you probably didn't expect it. If they said you had to be 5 days in the hospital, you would have said, for what? 5 days for what? Many patients historically spent 5 days in a hospital for a knee replacement or a partial knee replacement. So now we do a lot of advanced teaching. There's classes that we use to help educate people in advance of surgery. We figure out who has high risks, and we try to optimize their health before. So if you're diabetic, I'm going to try to get your diabetes controlled before you go to the operating room, not after. If you have an allergy to anesthesia, do we need a different type of anesthesia for you? Not everybody just gets general anesthesia, deal with it kind of thing. If you're nauseous, well, tough. No, we don't do that anymore. We don't want you to be nauseous. But Managing bleeding. So our transfusion rate is almost none for regular joint replacements nowadays because we use new medicines that help prevent bleeding. Similar to what they use when people have cardiac bypass. They used to give a medicine that helped you from clotting off. Now we use it in knee replacements and hip replacements. We have special types of coagulation devices that are less traumatic to your tissue, that are like a harmonic thing where there's a current that runs between two ends and it's very safe, and you kind of just paint the inside and bleeding stops. So there's different tools we use. Obviously minimizing surgical trauma so that there's less bleeding, less trauma. And so now when I talk about a joint replacement patient that is in need of surgery, I said, what do you need? What are your needs? Sleep apnea patients are a big risk for me. People that, especially those who don't like to wear their masks. You know, I'm fine. Well, we're going to give you anesthesia. That's someone that demands a little bit more monitoring, maybe a different set of medications that make you less sleepy. Patients that are very heavy, patients who are obese, can we get your weight down a little bit before surgery? Why is that so important? It's not meant to be offensive for the patient that we're accusing them of being heavy. It's meant to be, well, the thinner the layer of fat tissue between your skin and your bone, the smaller incision we make. The smaller incision we make, the less bleeding, the less pain. So if we can get a person who's 250 pounds to 220 pounds, the incision might be an inch shorter, just because we don't have to cut as much to be able to see. For patients who have kidney problems or breathing problems, are there different medicines that we can use for that person? Can we get their renal function better? Are they needing an evaluation by nephrology, which is a kidney doctor, before they go to the operating room? What about pain meds? I usually go through my pain meds with my patients. Have you ever taken Motrin? No, I'm allergic to anti-inflammatories. Okay, we got to come up with another avenue. Have you ever taken a Percocet? No, I get nauseous with that. Okay, we need to come up with another avenue. And now, rather than using the morphine pumps like we talked about, we actually mix a lot of meds. Like I use Tylenol and aspirin and Celebrex, which is an anti-inflammatory, and Tramadol. And people say, well, Tylenol doesn't do anything. Well, no, but Tylenol does this much, and aspirin does this much, and Motrin can do this much, and Tramadol can do this much, and you've got that much. Well, it turns out that much is almost as much as morphine. So we use a lot of different meds together that are safe to mix. Use the right quantities in cocktails so that you're not having a lot of pain. So I don't even order morphine anymore for my patients. And the ones that go home clearly aren't getting morphine because they're at home. And that's okay because they're managing with these meds that we're using. And I try to manage personal life issues. Who's going to be your support system? You have a lot of depression lately. Did you lose your job recently? Are you dealing with a personal loss? Do you have pets at home? Are you going to be able to tend to yourself? Do you have a spouse that you're caring for? All these things are really important beforehand because if we can help you, no one wants to kennel their dog, but maybe your neighbor can watch your dog for a week or two so you're not out walking the dog. Or you don't have anyone to drive you to get to groceries. Well, there are Meals on Wheels. Or can you cook and freeze food in advance of surgery so that you can just heat it up in your oven and instead of spending an hour in the kitchen cooking for yourself and having a cleanup? So the more preparation we do, each of those little things has a lot of value after the recovery. You know, the wife that says, well, I don't really want my husband to come home. Those are bigger issues. I don't know what to tell those people. So those people have to sort that out on their own. So how do we make this happen nowadays with advanced joint replacements? Again, it starts with teaching beforehand. The first time you come to my office, teaching, right? Going over what to expect. We send you to a class. I don't like going to class. The classes are mandatory. They're good for you. You get to prepare. You get to be in a room with other people who are going to experience the same thing as you, and they might ask a question that you didn't even think of. So there's value to those educational experiences. These doctor-patient relationships, again, me trying to figure out what's going on with that specific person so I can say, okay, you're a school teacher. We don't want to do this in October, right at the start of your school year. Let's plan for next June. You have a big driving obligation. Some people drive for a living. Okay, this is your right foot. This is your left foot. How long are you going to be out of work for? All these things are important as we're in the office trying to sort out how we're going to get you through this as quickly as possible. Preemptive analgesia, which is meds given before surgery. So when I do a joint replacement, they get 3 pills before they ever go in the operating room. Tylenol, an anti-inflammatory, a medicine that helps with anxiety and nerves, and also dulls the nerve sensations like a diabetic nerve pain called Lyrica or gabapentin. I give all those before surgery so that when they wake up from surgery, they're already kicked in and they don't wake up in a ton of pain. Managing the operating room, so doing the right surgery with the best tools possible, whether it's specific navigation tools. I use computer navigation for my joint replacements. We have specialized cutting blocks that can be matched to a patient's specific anatomy that are based off of CAT scan models. For certain patients, use either robotic tools. There's actually some virtual reality stuff coming out in the next 5 years where I wear a little pair of goggles and it'll say, your cut's off before you make it, and it'll show up in your eye. So there's a lot of cool stuff coming on the horizon that is not even where we are now with newer technologies in 2020. Obviously using, and again, I don't like saying minimally invasive, even though when patients, they do minimally invasive techniques, I say, yeah. They say, how long's your incision? I say, I can do it in 3 inches if we have to. But if I can't see, you would rather me make it 3.5 inches than 3, so that you have the best surgery that lasts you for 20 or 30 years. And all those things go to the patient experience. So again, we spend time prepping. Patients can prep on how to use a walker before surgery so that they're not trying to figure that out after they've had surgery. Understanding how to get home safely is really important. This didn't come up very well, but I have a medication calendar I give my patients on day 1, at breakfast, at lunch. What pill you're going to take? Well, that's not too hard. Well, if you're taking a lot of pills, it says you should take Tylenol at breakfast and lunch and dinner. What do I need Tylenol for? Again, these little things have additive effect. And people say, well, I'm only just going to wait till it hurts, then I'll take the oxycodones. Well, if you take all the Tylenols and the aspirins and all these little things, most of my patients don't need as many oxycodones. So 3 years ago, before we knew about all this whole opioid crisis, and again, it wasn't that I was being a bad person, but every surgeon was giving their patients 80 Percocets, 100 Percocets to get through a knee replacement, a hip replacement. I give them 30 now. Most of them are bringing the bottle back. I very, very, very frequently refill pain pills for my patients anymore. Nursing calls, we have a nursing hotline. So if there's a problem, you get a person who understands joint replacements. My wounds draining, we use a pain block. We put a little tube in your thigh that drips lidocaine in there for 3 days. You go home with it. It looks like a fanny pack. It just has a little dripping ball. You don't do anything, and it's less pain pills. But when that comes out, some patients say, how do I pull this out? Well, you pull the string. Well, I don't understand how to pull the string. Well, you call the nurse, or we'll send a nurse to your house. We use injections of different medicines now into the joint. So now I use a mixture of medicines that includes epinephrine, which decreases bleeding, numbing medicine, an anti-inflammatory, that we inject in your surgical site so that you need less pain pills. Again, picking the right people. Your smokers, people that don't necessarily have a good understanding of what's going on in their daily life, are not good patients to go sending home right away. So there are advantages to sending patients home early. We know that there are sick people in hospitals, right? Some people have pneumonia. Some people have reasons to be there for illnesses. So the sooner you go home to your home environment, the less infection rate. Less hospital errors. We hear a lot about hospital errors. Oh, they gave me my blood pressure medicine at 8 o'clock. I know I need it at 10 o'clock, but if I got it at 8 o'clock, I'm wrong for the rest of the day. You know you better than we know you. So there's less errors when you're the one managing you, as long as we give you the tools to manage yourself safely. You eat your own food better. You sleep better when you're sleeping in your own bed. Some people sleep in a recliner, but it's not a nurse coming in your room at 4 o'clock in the morning for your blood pressure. And patients tend to be happier from a satisfaction standpoint the sooner they get home. There's also advantages of not sending patients to rehab. You get a less risk of a blood clot. Why? When you're at a nursing home, they bring you a bedpan. You lift your butt up in the air, they put it under your bottom, you go pee, you never had to move. When you're at home and you got to go pee, you got to get up and move your legs to the bathroom. That circulation helps you recover faster. It makes you move, it decreases blood clots, it decreases swelling. So it actually helps you get better faster. And they're predicting, we already know that in the early 2010, 2011, when you had yours done, joints were just starting to move. So now almost 100% of my partial knee replacements, called unicondylar knee replacements or UKs, almost all of those go home same day, unless they're very ill, like a 90-year-old. Even a 90-year-old could probably go home. Many of my hips go home the same day. And I would say about 90% of my knees, hips, and partial knees are gone with less than 24 hours. People aren't staying that long anymore. But we need motivated patients that are going to be compliant with the instructions, don't have a lot of health issues, have a good support system at home, understand how to use their flip phone or their iPhone so that when there's a problem, they can pick it up and call us. Flip phones always scare me when people sell flip phones. Understand how to take the pain pills because they're all oral. They're not injected into you. You're not going home with shots. You're going home with pills. And you need you to understand which ones are the right ones to take. And I explain it, and we print it for you. And then obviously the goal is to get people rolling a little quicker. So that was a quick talk on joint replacement. I can go down some other avenues if that's an interest area for anybody. I don't know how long this is slated for, Carolyn. Okay, so we got 15 minutes for questions, if that's good for you guys. So the implants of the early 2000s had a lifespan of anywhere from 15 to 20 years with regard to knees and hips.
So are they equal, knees and hips?
Hips tend to last a touch longer. There are factors that can change that, namely what you do with them. So again, the heavier you are, the quicker they wear out. People that try to run on their implants, or skiers, or if you're playing singles tennis, I always tell my dad it's a tire. My dad's got 2 hip replacements. I was like, Dad, you get 60,000 miles. And 60,000, my dad plays racquetball every day, like in knucklehead. He said, I'll just put new tires on then. I said, well, that's not exactly what you're hoping for. But he's like, that's why I put you through college, Brian. But it's your body weight, your activity load, your age. So we know young males wear out joints. The younger you are and the more male you are, the more quickly you wear it out. Why males? Males tend to be more foolish than females, I suppose, and they tend to be more impact on their joint replacements. Hip replacements do last longer now because we, for the most part, for most individuals, use implants that grow into your bone. So they're porous ingrowth coated type implants. Most knee replacements are done with a kind of a cement bonding that, in essence, glues them to your bone. And your own bone can regrow and heal that connection, but the cement doesn't heal. They do have some implants on the market that are knee replacements that do ingrow. I haven't jumped over to that yet because they haven't been around as long as I'd like them to be at least 10 years in before I go do something new. I'd like to have a track record a little bit. But all those things play important factors in longevity. And I mentioned the implants of the early 2000s, so they've recently changed. Now I use all ceramic. I don't use metal balls anymore. And the plastics have gotten better in the late 2000s. So those, they say, may go up to 30 years, but it hasn't been 30 years yet, so we don't know. But the general rule of thumb I tell people is 1% fail per year. Meaning, at 5 years after a joint replacement, 5% have failed. Now, usually it's because something was infected, or maybe they broke a bone, but that's considered a failure if the joint had to be worked on again. Usually the actual ones that wear out are in the second decade of the implant's life. You got a question?
If both knees need implants, do you do 2 at once?
I try to discourage people from that. If the question you're asking is, can you do both knees at once? The answer is yes.
Somebody that had both done, that surprised me.
Yes, so that was actually more mainstream. I think we've gone away from that. The reason why is, one, as we're trying to get away from the opiates and get people moving a little quicker. If you don't have any good leg to kind of help you, then the rehab's a little slower. Secondly is 2 surgeries hurt more than 1 surgery, so you take a lot more pain medicines. I did a guy a couple years ago who overdosed on a pain pill when I did both his knees the same day, so I'm a little timid. I usually reserve that for very, very healthy people who have a compelling need, like they're a school teacher, they mistimed their summer, and it's August, and we're running out of time. But for the most part, I try not to do that because I think the risks are not warranted. Because the old mindset was anesthesia is a high enough risk, you should only do it once. That's not the case anymore. So we don't do general anesthesia for joints. We do a spinal anesthetic, like when a woman delivers a child and they inject numbing medicine into your back. We have quick-acting numbing medicine that's exceptionally safe. It lasts for about an hour and a half, which is all it takes to do a joint. And it's worn off. And you can be awake during surgery if you should choose. We usually kind of snooze you with like the same stuff as when you get a colonoscopy. But the risks of anesthesia are so low now, and the risks of bleeding are so low now with this new medicines that we're using. There's not an advantage to a patient to do both, but there is a risk. So there's a stress to the body. Yes, sir?
On hip replacement, anterior versus posterior.
So there's five approaches to hip replacements. You just hear about anterior most commonly. There is anterior, there is anterior lateral, there is direct lateral, there's posterior, there is the 2-incision hip, and there's superior, which sounds like it's better because it's superior. But they're all, for the most part, using the same implants, and the duration of the life of the implant, assuming they were done well, should all be the same, regardless of the surgical approach. The purported benefits for an anterior approach surgery are that there's planes of the hip that we go through. There's 2 muscles in the front you can go between, 2 muscles on the side you can go between. This one goes through the muscles, the direct side one. The back one, most of us stay above the gluteal muscles, although, again, if you're doing a big incision, you're going to end up cutting the muscles. So there are guys who do minimal posteriors and guys that do the big old school posteriors, which do cut a lot of muscle. I think the market has gravitated toward just anterior and posterior because lateral has a lot of side effects with limping. Superior is just kind of trendy to say. Not a lot of people do it. So it's kind of a West Coast thing right now. It's where it's kind of emerging. I think that there are some purported benefits that would say that anterior might help you recover a week or 2 faster. Maybe. I've done anterior. I've actually, through my training in Chicago, had the opportunity to do all of them. Anterior lateral, direct lateral. I don't do direct lateral anymore because of the limping side effects. Anterior lateral, I think, is no benefit to anterior direct. So most guys either do direct anterior and direct posterior. And I think we all kind of go in waves. So 3 years ago, if you asked me this, I was doing mostly direct anteriors. And then you have a couple consequences because I think that surgery carries with it a couple higher risks. The direct anterior surgery has 2 main risks in my mind. Firstly, for folks that are very heavy, if you have a belly that kind of folds over your groin crease, the incision is in the groin crease, and there's a little risk of wound infection if your belly sits on your scar because it's a little bit moisture tissue in a fold, and some people even have a little bit of like some white kind of fungusy, junky, whatever, and so those people are bad candidates for anterior. The other is if you have very frail bones and you have to lever up. So heavy folks and people who have bones, when you do an anterior approach, you either use the table that we use has a jack that actually lifts your bone out with like a hydraulic jack, or you can use a hook and crank it out with a hook. That action does place a lot of stress on the bone that is not present with the other approaches, and there's a slightly higher risk that you can get a break of the bone during surgery while you're doing an anterior approach. Again, it's a risk-benefit analysis for who that individual is. This anterior approach is very good. It's fun surgery. I enjoy it. It's very clean. It's very nice looking. But a good done posterior surgery is equally efficacious. And I actually think, because I do outpatient posteriors, there's not any really, it's a little bit of marketing hype as well, I think.
So what goes into the decision-making process of the surgeon in terms of which way he's going to go with this thing?
So I think the firstly is certain surgeons were only trained on one way, and they're going to do that way. So part of it is picking your surgeon. And I know the patient is picking an approach, like you're going to go on, I want to pick an anterior approach. You should really go on and say, which surgeon has the best outcomes? And then probably you should trust that doctor to give you what he thinks he does best. So it would be like you coming to me and say, I want a lateral. Okay, I think that's going to be really bad for you. Yeah, but I heard lateral's great, and it's going to be awesome. All right, I haven't done that one in a couple of years, but I can do a lateral if you want. So I think you should pick a good surgeon. Secondly is you should understand, or that hopefully that surgeon will explain those risks to you. Okay, perhaps you're a little heavier you might not be a good candidate for that, or guys who are very high, very thick quad muscles. The quad muscle overlaps the surgical site for an anterior, and some guys we actually kind of release the quad a little bit so that muscle sparing kind of becomes equivalent to the other approaches on really thick rectus muscles for those guys. So I think you should go to the surgeon and say, I've got bad hip arthritis, I'm interested in the fastest recovery possible, and I think you should solicit which is a good surgeon, not the surgical approach. Because I think what bad cases happen is when you try to come in and say, I like this implant with this, put it in this way, and you have a problem. I honestly think that if you go to a doctor that does a very good anterior, their fracture risk is very low, their recovery rate is going to be very quick, and you're going to be very happy. I think if you go to a guy that does a very slick posterior hip, and you know that's all he does all the time, you're going to have a very small incision. You're going to get up and walk that same day, and you're going to be very happy. I think when you try to steer the ship too much as I don't want to say a non-medical person, but a person who doesn't have all the training to make that clinical decision, you're just looking at the reason why anterior is marketed as so much faster is because it's a Philadelphia versus New York thing. Historically, New York was a very posterior-based town. Philadelphia was an anterior-based town. The Philadelphians are a little louder than the New Yorkers, ironically, and so it's marketed a lot more aggressively than posterior. I honestly think, in truth, that they're equivalent. The restrictions from an anterior versus a posterior, during a posterior approach, we usually don't want you bending and twisting for 6 weeks. And in the anterior, we don't want you laying on your belly or hyperextending. But some anterior surgeons don't let you bend and twist either. So that benefit might go by the wayside depending upon that surgeon's assessment of your joint. So again, I think that, anterior is very good. I did it for a couple of years, had a couple fractures, and I did one a week ago, and someone talked me back into it, and then her wound gapped open because her belly, I had to tape her belly up out of the way to get the surgery done, and then her belly fell back down after the tape came off. Can't walk around with tape on their stomach for 6 weeks. So I think you should really go to the surgeon and say, I'd like the quickest recovery possible. What do you recommend? And you should pick the surgeon who you go online, read your reviews, talk to your friends who've had good surgical outcomes, and there's not an actual superior one. Depends if you're from Philly or New York.
So where are you going to stay in the hospital, but I'm hearing 6 weeks?
So the pieces still grow into your bones. So for a hip replacement, for example, the porous coated metal does have to grow into your bone. That doesn't happen overnight. We actually hammer them in and they're wedged there. Sometimes we even put an extra screw or something to hold them there. But your body actually grows through the metal. And as that's going on, we do want you to be cautious. So, I always remember I had this lady dislocate her hip 3 years ago because 3 weeks out she felt pretty great and decided she wanted to go weightlifting. Okay. And then your hip popped out. Well, you weren't healed yet. Even though you didn't feel the pain, that doesn't mean your body was yet ready to do that. I can remember my 3 folks who've had major complications, and in recent times, one of them was on a ladder and fell off the ladder because they didn't quite have the strength to be on a ladder and catch themselves when they slipped a rung. The weightlifting individual, and then another person who was a little too heavy, and I probably, underestimated that 300-pounder and should have reinforced a couple more screws in that guy. So, for the most part, we're all doing it. We're trying to be cautious on your behalf. So, you can get up and walk. You're not wearing crutches for, a month. You're walking for that month, but you're not mowing the lawn that month or plowing the driveway.
How about stairs?
Stairs you can go up the same day. Same day, unless you do both knee. If you do knee, you go up with your good knee and you bring your other knee with you. So you can go upstairs the same day on a knee, on a full knee or a partial knee.
So on average, I know there's no average.
Sure.
Following surgery, you got a 6 to 8 week window conservatively.
Sure. I think that's a...
Don't do the big school.
Yeah, so for example, I have some folks who are business owners and they say, how quickly can I get back to work? I have a business to run.
Right.
Again, if they're non-manual laborers and they're just going into their office, I usually say give yourself a week or two and go back to work and have someone be your gopher. You know, for my folks, like I'll have a lot of people who work on ladders like AT&T or Verizon, and they're up on, you know, those folks I have out for 3 months, because if you go up a ladder and you weren't quite ready, there are some catastrophic side effects. So it's very obviously individual based, but I think I usually tell people, you know, your desk jockeys are probably fine after a few weeks, but people who are school teachers on your feet for a lot, you know, you might need six weeks to kind of be prepared to stand in front of a classroom and lecture for hours on end. Driving for me is 3 weeks for most people, as long as they're getting their range of motion on their knees and they're off narcotics. Yes, ma'am.
Partial knee versus full knee replacement. Does that depend completely on what's wrong with the knee, or by having a partial, do you catch something earlier?
So partial knees is a philosophy. Again, I think a lot of young guys who come out of training nowadays I'm a very big proponent of partial knees. It does depend on what's going on in the knee. So that one x-ray I showed you, this one, where the disease is really localized to the inside of the knee. Obviously, this is one x-ray. We need x-rays of the kneecap. We need side views. I usually do a stress x-ray to make sure that the MCL is intact. I push on the thigh and try to straighten the leg out, make sure that everything's flexible still and hasn't gotten too stiff. We might just replace the inside of the knee alone, which is a shorter surgery. They're almost always outpatients. They feel a lot more natural because it's not a full knee. It feels like your knee. In a partial knee, usually you have an intact ACL, intact PCL. On a total knee, usually the ACL is not maintained. And sometimes the PCL is taken out as well because they're not functional with the total knee replacement. The knee replacement replaces those pieces, but they're not your own. So a partial knee is good for the right people. So a lot of young people who only have isolated disease can get away with a partial knee replacement of either the inside, the outside of the kneecap. Usually we talk about the knee as 3 parts. So it's almost 8 o'clock. So I will stay around for anybody that has individual related questions. Our ankle friend has left, but I'll be here for a few more minutes if you guys want to talk or any specific questions that pertain to you that you didn't want to ask in front of the group. Thank you for taking the time on a night. And hopefully, if you guys do need any work done on your joints, find someone that listens to you. That's the most important part, because that's where you identify all these little things that help you get through the recovery faster. Thank you, guys.